Welcome, Andras. We're so happy to have you back today. This is, I think, the third time you've presented for us at Peds Echo, and we always learn so much. We're continuing our cardiology theme for the month, having heard from one of your partners last time, and we're looking forward to hearing about chest pain. It's certainly something that's very common and mostly not cardiac. So obviously we always worry about missing that one that is really cardiac, and we're looking forward to getting some pointers on that and other things from you. As usual, I will monitor the chat so that if there's questions for like clarification or sort of like right in the moment questions, I'll probably interrupt you at that time, and otherwise we'll have plenty of time for questions at the end. Dr. Brattenstock, go ahead and take it away. Thank you so much.
Thank you very much, Maya. Thank you, Summer, for inviting me and letting me share whatever I experienced and learned along the ways, and then welcome everybody. I would like to make this as interactive as possible. So I have slides to share. I have some things that I would like to um, go through, but please interrupt me and ask questions because I think that's the best. So let me share my screen, and then hopefully when I switch to presentation mode, you will still, oh no, you see the other. Do you see the full or you see the partial?
We see the first slide and then it's the dark screen with the notes on the right.
Okay, so I think I have to switch then presentation. Okay, we'll just have to share the different window, or I could, yeah, I'm gonna share the other screen, and now you should be seeing the full.
Perfect.
Yep, now we can see it.
Okay, cool. Thank you very much. So again, common cardiac problems, I would say this is probably on number 2 and number 3 on our outpatient visits, chest pain and syncope, among many other things. So these are really two things that we need to kind of identify how we can sort out the cardiacs from the non-cardiacs. And it's truly finding a needle in the haystack, because you will see it's like 1% of the overall presenting children with these symptoms. I don't have any conflict of interest. You saw the objectives. So objectives, again, try to figure out those specific hallmarks of chest pain that points to a cardiac origin, and remember those as red flags. And then also do the same thing with syncope, differentiate among the different types of it, and then see when you really need to get into cardiac evaluation. And then what is the appropriate workup, the initial workup for both chest pain and syncope that you as a pediatrician can start in your practice without or even before referral to cardiology. So my favorite slide is like um, a crime scene that we need to investigate. And I think the most important part that you will see is history taking. And there are specific questions I like to ask, and I think that will help us get to the right diagnosis. So just a starter, for this is between 98 and 2011 because the publication was in 2013, but you can see that's probably continued on in the last decade. The visits with chest pain and syncope in the ER in a certain center is continuously increasing. And for chest pain, it's super common. About 0.5 to 1% of all ED visits are due to chest pain. And this is number 3 on a pediatric cardiology visit in a large center when they compare to all kinds of visits. So chest pain is a really common visit for ED, for pediatric cardiology. And you can see 1 out of 5 children will experience chest pain in their childhood. So it's a super common problem. And obviously, not 1 in 5 has a cardiac disorder or even a cardiac etiology of chest pain. Less than 1% of all chest pain is caused by a cardiac etiology. So how do we find that? So when you look at an AAP recent publication, a review article, then you see all kinds of other reasons. And these are what occupies 99% of the chest pain reasons. It can be psychogenic due to anxiety, musculoskeletal, which I think is the most common, because of actually growing pains. A lot of times the growing pains are not only in the hips and knees, but they are in the sternum as well. So that's skeletal, but your muscles can hurt, all kinds of things can happen that makes you hurt. Respiratory is a little more rare. Asthma is listed there, but if you talk to our pulmonary colleagues, I don't know how many of them really say that asthma can cause chest pain. Pneumothorax definitely can cause chest pain, so that's a serious issue. So that can be ruled out. But I usually say that when you have chest pain, you don't have heart pain. A lot of patients, when they present to me, they say my heart hurts, and I try to rephrase it to them. It's like, yes, you have pain in your chest. That doesn't mean that your heart hurts. Actually, you have a lot of stuff in your chest that can be painful. And again, this is just a simple summary in what the 99% consists of. But I'm not going to go into this. I'm going to go into, the all the other side. So when you take a chest X-ray, this is just like a funny picture. When you got to think, when you have chest pain in pediatrics, you got to think outside the box, because outside the box will reveal the actual issue. When you have chest pain in a 50-year-old or a 90-year-old, you have to think about cardiac, but it's kind of the opposite in pediatrics. Again, 99% is not. Musculoskeletal, again, that's the most common. How do we pick up on musculoskeletal? I think it is good just to go through this extra cardiac origin for a second, because this can reassure you that it is musculoskeletal. It usually is precordial, mid-sternal. It does not radiate in the neck, in the left shoulder, or the left arm. It lasts only seconds to minutes. And I think that's the most important. And that's what I always ask. So one good question to ask in history, how long is your chest pain? Because when you will see, I'll present the cardiac reasons for chest pain, those cannot last for seconds or minutes. So you can just totally rule out all cardiac origin if you can figure out, oh yeah, that sharp chest pain lasted exactly 30 seconds. Well, no cardiac origin can last 30 seconds. So I think that's one of the most important history questions I usually ask. Then the second one is, how does it affect your breathing? Oh yeah, I want to take a deep breath and I just cannot. It's just like even more painful. So I stop breathing. I don't take a deep breath. And now I'm going to usually ask revealing questions to the patient. So what do you think moves when you take a deep breath? And oh yeah, my chest cavity. And like, that's exactly right. That's what hurts. So that's another typical question I usually ask. Does it change with breathing? Does it make it more difficult to take a deep breath? And then resolve without any intervention. That's also a hallmark, especially if it's a couple of minutes. So again, these are history questions that can lead you to confirm that it's not a cardiac origin. So what is the cardiac origin? What is the needle in the haystack? At the cardiac origin, we'll go through, I usually list 4. So this is part of that review article that I presented you before. And these are some hallmarks in the history that can point toward the suspicion that you need to work a little bit more and figure out whether the chest pain is cardiac or not. Number 1 is exercise. So if the chest pain happens in the middle of exercise, I would always be a little more cautious, because that's when you really push your heart to the limit. And then if there is an ischemia or any issue, a lot of times that can happen during exercise. The next one is trouble breathing. So we just went over it. It's not more painful when I want to take a deep breath. No, it's being short of breath constantly, not for just 1 second, but like, a longer period of time. So trouble breathing really doesn't mean, oh, it's more painful when I take a deep breath. It's shortness of breath. Getting tired easily, meaning like having less exercise tolerance. And it's more of if the pain is like a dull pressure, like an elephant sitting on the chest, and not like a sharp pain, like a stabbing sharp pain with a knife. A stabbing sharp pain is more musculoskeletal. A dull pressure could lead to a potential, or could reveal a potential cardiac cause. And obviously, If the chest pain was around syncope, that's also another red flag. So again, you can see all of these are in history. So if you can touch base on these points, I think you can recognize or have a good idea whether you are dealing with a cardiac origin or not. And then, so let me just go over a couple of cardiovascular etiologies of chest pain, and that can help. I believe it helps reinforce when you are talking to these patients. So there are two and a half cardiac origins and two vascular origins. And when I presented this talk about 1.5 years ago, or a variation of this talk, I emphasize this. I do this during my exam and history taking with the patients in the waiting room, because it helps them understand and helps them leading to the point that, oh, it's obvious that my chest pain is not cardiac. So I list the the only cardiac origins and the only vascular origins of chest pain. And the vascular origin is aortic dissection, pulmonary embolism, so heavy duty stuff. And the cardiac origin is pericarditis, perimyocarditis, but pericarditis or myocardial ischemia. The third one, supraventricular tachycardia, is placed there. It's not because it causes chest pain. SVT does not cause chest pain. But when you are dealing with a 5-year-old may not be able to tell you, is that painful or is just something that I feel? And a lot of times the palpitations, the weird chest pressure or weird feeling can be communicated to doctors' parents as chest pain. So that's why SVT is a common cause, but it truly does not cause chest pain. It just causes some sort of chest discomfort that little kids can be interpreted as chest pain. So let's go over this step by step. Start with pericarditis, the most common cardiac cause of chest pain. It's rare, even though it's the most common. It usually is idiopathic. A lot of times it's viral. Can be associated with all kinds of carditis like rheumatic heart disease, MIS-C, maybe even Kawasaki disease, but it's an inflammation around the heart. The chest pain is very typical. It is substernal. This one does not radiate into the left arm and the left shoulder. It has a typical positional change. The chest pain is somewhat relieved when you lean forward, and maybe is a little bit worse when you lean backward. What is important is that it's an inflammation. As an inflammation, it cannot happen for 20 seconds. So I usually compare it to sore throat, and I ask them, okay, so what do you think? How long is a sore throat? Oh, yeah, it's a day or two, a couple of days. That's exactly right. That's how pericarditis is. It's a couple of days. It doesn't go away. It's a constant substernal chest pressure. Oh, that's true. My chest pain only lasted a couple of minutes, so it cannot be pericarditis. The inflammation is in the pericardial sac. Because of that, the nociceptors are correlated with the phrenic and intercostal nerves. So the chest pain is projected substernal, right where the pericardium is and not elsewhere. So again, this is the most common. It lasts days, at least a day, not more than 20 seconds, and it is in the substernal region. The other cardiac is myocardial ischemia or infarction. And you can imagine this is truly very, very rare in pediatrics. And it can happen mainly for now again, 2.5 reasons. So Kawasaki disease is one. Now MIS-C is in the picture here, but one caveat with MIS-C that you see coronary artery lesions, much less in MIS-C, and you see more pericarditis and decreased function. So I will still put Kawasaki disease there. And the super rare congenital coronary artery abnormality. And if you think about this, Kawasaki disease comes with a full picture, febrile, all that jazz. So it's very rare to miss that. Nevertheless, when somebody comes with exercise-related chest pain, I always ask, did they have Kawasaki disease in the past? So I think that's also a good history question to ask. had they ever been diagnosed with Kawasaki disease. And the other one that we need to rule out in pediatric cardiology is a congenital coronary artery abnormality. And I will show you a picture in a sec, but first I would like to display the chest pain. So the chest pain that is related to myocardial ischemia and infarction, again, cannot happen for 20 seconds. It doesn't happen for 1 minute. It's something that lingers at least 30 minutes, but usually it is there for half of the day or until some intervention is done. This pain radiates. This is not substernal, not in the middle of the chest. It radiates to the neck, left shoulder, and left arm, and usually is only relieved by certain intervention. So again, you can see how super important it is to make sure that the chest pain is not just a couple of seconds. So why is it related to the left shoulder and the left arm? Because the nociceptors inside the heart, they are projected to some other dermatome, and that's why you have to usually localize it to the left arm. Again, this does not relieve by this usually is relieved by some sort of therapy. So again, it's longer, and the most important part, Kawasaki disease and an anomalous coronary artery to rule out. Then the two vascular problems are aortic dissection and pulmonary embolism. I've personally never seen an aortic dissection in a child. It's not like it cannot happen, it's just more rare. Even with Marfan syndrome, Ehlers-Danlos syndrome, and Lewis-Dietz syndrome, those typical aortopathies, the dissection happens in young adulthood in their 20s, 30s, and 40s. And here you don't need, again, any kind of cardiac exam. Usually you need to rely on your clinical diagnosis to diagnose those syndromes. The pain in aortic dissection is an excruciating mid-chest pain. It radiates to the back. Obviously, this is not 20 seconds, right? So again, so important to figure out, is that chest pain only for like a minute? Because this is excruciating until the patient dies or gets appropriate therapy in the ER. The hemodynamics are unstable. This is impossible to miss. So again, that's why I explain this to the parents and I say, oh yeah, no, it's clear cut. It is not what it is. The dissection usually happens in the aortic root, ascending aorta, and the pain is related to the thoracic spine. That's why it radiates to the back and it's midsternal. And the last one is pulmonary embolism. This is also extremely rare in pediatrics. It happens usually with an underlying disorder or coagulopathy, sometimes related to indwelling catheters. So patients who are hospitalized, hem-onc patients, can have pulmonary embolism. The chest pain usually is on the side, not in the middle. Again, now for the fourth time, this is not for 20 seconds, not for a minute. This chest pain lingers for hours or until appropriate therapy is initiated. Usually is associated with difficulty breathing, hypoxemia, and then it's related to the area which is being infarcted. So the infarcted lung area and the pleura is that actually painful. So it's really on the side and not in the midline. So again, these were the etiologies that are theoretically related to chest pain as a cardiac origin. There were a couple of articles that put this nicely together. Here are the list of articles from the 70s to the early 2010s. And the best article was the last one that you can see, Saleb et al., that collected 3,700 pediatric cardiology visits and found out that actually exactly 1% of those had a cardiac origin. So when you break down that article, you can see that most of the diagnosis was SVT. And so that's kind of unusual. I just told you SVT does not cause chest pain. It is super rare for SVT to get to a point to cause ischemia. So a lot of times that chest discomfort was related to the provider and the parents as chest pain. And if you look into this article, the patients who reported SVT caused or resulted in chest pain, those were on the younger side, less than 10-year-old. But then you see the next three is pericarditis, myocarditis, and anomalous coronary artery origin. There were another summary article that looked through all of those publications that I showed you before. And again, pericarditis was the most common. SVT was again common. And you can see some other extremely rare cardiac etiologies for chest pain over the last 3 decades. So for a patient who comes to pediatric cardiology and we think they may have a cardiac origin, we usually need to rule out number 1, pericarditis, and number 2, coronary artery anomalies. And how do we do that? Well, pericarditis is usually ruled out by an EKG, and coronary artery anomalies are usually ruled out or at least suspected, not suspected, by an echocardiogram. So you see, now we are 25 minutes into the chest pain talk, and this is the first time I mentioned echocardiogram. Echocardiogram is really not an appropriate test to figure out what's going on in relationship to chest pain. And that brings me to another review article that's also in Pediatrics that told you what is the appropriate use of echocardiogram. And you can see on the top, it's exertional chest pain. That's when you need to find or need to order an echo. And I think the most important part here is history taking. The other one in that first row is a chest pain with a family history of sudden unexplained death in an early age, less than 50 or less than 40 years of age. So that's a family history red flag, and then it's a personal history red flag having exertional chest pain. But that's the most important. This article summarizes the things about chest pain. So most common identified etiologies are musculoskeletal, and they are not cardiac. Cardiac etiologies are exceedingly rare. Basically, what you would need to do is history, and consider an EKG. And if there is chest pain during exercise, that's when you can consider an echocardiogram. So again, action is truly a very thorough history taking. How long does the chest pain last? Is it together with exercise or not? Which side does it hurt? Is it stabbing, sharp, or is it dull? And then, do you have anybody in the family who died young? Have you ever had Kawasaki disease and these kind of things? A little bit of physical exam, because the physical exam, usually if they have chest pain, they don't have chest pain in your office. They had chest pain before. So you really need to dig into the history. The physical exam is only relevant if you suspect maybe an aortopathy. So that would be worth. And then about testing, I think EKG is useful, but it's the most useful during the chest pain. So if you see somebody in your office who said, well, I had chest pain before and chest pain here and chest pain there, you can send them to have an EKG, but the yield of that EKG will be very low. The EKG will be best if it's getting when the patient has chest pain. So a lot of times I relate to them, if you have chest pain next time, yes, please go to the ER and get the EKG while you have chest pain, because that will be the most useful for us. And then what do you look for the chest pain? What do you look for in that EKG? ST segment elevation. So if the patient has chest pain and has ST segment elevation, just like this EKG demonstrates, usually lead 2 needs to be significant, you can suspect pericarditis. Again, the most common cause of chest pain in pediatrics. It can happen also more significant, like on this EKG. There is ST segment depression here, and this is because of myocardial ischemia. It's super rare, but I decided to show it to you because why not? You will not see this. It's very, very, very uncommon. So what do we need to diagnose it? Well, perimyocarditis, EKG is perfect, history helps. I don't even need to get an echocardiogram unless you are concerned of some other history elements. The next one is coronary artery anomaly. The concern comes when the chest pain is exertional. Again, there is the red flag, exercise-related chest pain. And then in that case, you need to get an echocardiogram. So here is an org chart for that American College of Cardiology and AHA article that tells you when it is appropriate to use echocardiogram. And then just look at the green elements. You don't need to look at this whole thing, but you look at the green on the bottom, you trace it back, you see chest pain, exertional, chest pain with an abnormal EKG, or chest pain with a family history of unexplained sudden death. So what do we need to do with chest pain? Get a good history. If it's exertional or there is a family history of sudden death, you may order an echocardiogram, but in my opinion, you absolutely need to order an EKG at the time of chest pain or even unrelated to that. I just wanted to show you the picture of that anomalous coronary artery. That is again super rare, but you can see that the coronary artery here travels between the pulmonary artery and the aorta. And you can imagine when the patient exercises and their cardiac output doubles, the pulmonary artery and the aorta dilate a little bit, and they crush that anomalous coronary artery in between. That causes chest pain. Chest pain does not happen at rest, does not happen when they bend over when they wake up. It happens during exercise. So that's why it's so important to ask whether the chest pain happens at exercise. Okay, I don't want to show you pulmonary embolism because that's not really needed. There are some MRI pictures here about gadolinium enhancement, how you can figure out myocarditis, perimyocarditis. But again, this is not needed for this talk. Again, here, summary, green flags of chest pain. That means it's not cardiac. Hurts right here in the middle, lasts only a few seconds to a few minutes, changes with breathing. And the red flags are it's excruciating, it does not resolve without intervention, and it happens during exercise associated with fainting, or there are two physical hallmarks there. One of them is a median sternotomy. The patient had a heart surgery, but I don't think so. That needs to be figured out by a pediatrician in their office. The patient should be hooked to cardiology. And the other one is a severe pectus excavatum, which can suspect pneumothorax or some aortopathy. So that's the chest pain part. I'm going to take a tiny pause here and see if there are any questions before we move on to syncope.
There was one question in the chat, and I think it was referring to the location of pain if you had a PE in the middle lobe. I mean, I'm assuming meaning the right middle lobe, if that would radiate any differently.
I think that's a very relevant question and legit. I bet it would radiate exactly where the infarction is and where the pleural irritation is. So it could be not on the side, but could be more anterior. Correct.
Okay. And then I wanted to just quickly ask, a lot of the public health messaging about heart attacks is that, the symptoms can be atypical in women. And it's such a rare thing in children in general. Is there any data as to whether symptoms are similar in children who are born female and those that are born male, or is there no difference? Or do we
Great,
not know?
great question. And we have absolutely no data because it's so rare that you cannot even put together a worldwide cohort. So no, I have no idea, and I don't think so anybody has data on that.
Okay, I figured that might be the answer.
Yeah, unfortunately. Or fortunately.
I mean, it's good that it's rare. Yeah.
Right.
Okay.
Yeah.
Super. Thank you. I'll let you go on. I don't see any other questions in the chat.
Thank you. So this next part is about fainting spells or blackouts or syncope, and how to figure out exactly, Is that cardiac or not? And you will see some similarities between this and chest pain, but it's not exactly the same. The similarities, though, it's that history taking is the most important weapon. Uh, Definition, and this might be important just so that we speak the same language. If somebody is hypoglycemic and in a coma, does not have syncope. If somebody has a tonic-clonic convulsion and is not conscious, they did not have a syncope. A syncope is an abrupt and transient loss of consciousness with usually rapid and spontaneous recovery. If somebody needs to have CPR, that's not a syncope, that's sudden cardiac death or arrest, right? So it's important what we mean by syncope, and usually the reason for syncope is an acute loss of cerebral perfusion, or maybe not loss, but acute cerebral hypoperfusion, which results in a transient switch off of alertness. So again, transient loss of consciousness due to cerebral perfusion, rapid onset, and usually spontaneous recovery. That is syncope. So now that we said that, I also just want to show you a couple of hallmarks. So that is epidemiology of syncope. So syncope is the number second. So chest pain was number 3. Syncope is number 2 among pediatric cardiology visits in a large single center study. It's again about 1 in 5 children, same as chest pain, 1 in 5 children will experience syncope in their childhood. So now if you think about it, chest pain and syncope, 2 out of 5 children will experience it. So it's super common. So I think every pediatrician comes across that. And because it's about the same, it's the same in the ED visits. It's 0.5 to 1% of all ED visits. And it's very similar also in the sense that less than 1% is because of cardiac origin. So what are the types or etiologies of syncope? The most common is actually number 4, neurally mediated, which is appropriately now called neurocardiogenic syncope. Even though neuro and cardio is in there, none of the two are wrong. It's just mediated by the brain and the heart and the interaction between the two of them. Cardiac is 1% or less. And you can see there are some other reasons, which we are not going to go into detail. My whole aim is to try to focus on when you have syncope, how can you tease out whether that is of cardiac origin or not. But again, most common, which I would say more than 90%, is neurally mediated or neurocardiogenic, or, like previously it was called vasovagal or common benign faint. All right, so we are looking for that 1% needle in the haystack again. Before we hunt for the cardiac causes, let's just go over a little bit the non-cardiac. So among the neurally mediated or neurocardiogenic, which previously was called also vasovagal. Vasovagal is just one kind, but you can see here there are all kinds of other neurally mediated syncopes. And again, this is the most common part. That in tiny kids, what is there in like a weird green or yellow color is breath holding spells. So when kids get so wrapped up, and this can happen after 6 months of age, peaks around 9 to 12 months of age, and it can go easily into the 2 years and the terrible twos. They get so wrapped up and so mad, and they're crying so hard, they are holding their breath. They actually drop their saturation to the point that their cardiac output is compromised because they cry so much that their SVC and IVC inflow is limited, and they just pass out. It's like try yourself holding Valsalva as long as you can and stop breathing, and then you will eventually pass out. It's the same thing, and there is nothing wrong with the heart here. And so when you pass out, you drop your saturation and your heart rate goes down and so on. And when you passed out, then finally your brain turns off and then you can stop crying and start breathing, and then you wake up by yourself. So I was lucky or unlucky enough that I experienced this full on in my clinic while I was listening to the child, and was cried so hard because I was bothering him while I was listening to him, that passed out in front of me. And yes, it is scary because a tiny nine-month old turns blue and passes out, but this is a benign neural mediated thing. It does not require any cardiac intervention. It requires soothing. And so sometimes it's difficult to get into this because, at the end, the parents are so neurotic about it. They don't let the child cry because they are afraid that the patient will pass out. But that's more common in little kids. When you get older, orthostatic hypotension is the most common reason. And so I would like to again take just a moment here to differentiate POTS and orthostatic hypotension. Because quite honestly, as a cardiologist and an electrophysiologist, I detest the diagnosis POTS. I really don't like it because you can easily put it on a patient. And POTS is actually a very significant diagnosis, which means that you have an orthostatic tachycardia syndrome that lasts for more than 10 minutes. Orthostatic hypotension and related tachycardia is a normal response to every single individual. Once we get old, we will have less and less on that, but a young, healthy teenager does have orthostatic hypotension. So I'll show you in a slide that is coming up how is that mediated. So reflex syncope is a little different because reflex is like I see blood, or I have pain, or they poke me with a needle, and they freak out so much, they have such a vagal response that they stop beating. They have asystole for 10 seconds, and of course, nothing goes to the brain, so they faint because of that. Vasovagal is a very specific syncope that usually happens when you are standing upright for a longer time, and it's not the orthostatic hypotension. There is a compensatory part where you compensate for it, and eventually you run out of the compensatory mechanism, and then you faint afterwards. And POTS is a very specific diagnosis, and I would say, again, truly very little patients get the POTS diagnosis. A lot of patients will just get orthostatic hypotension. So these are the most common. This group here is is the etiology for 99% of syncopes. So if anything, it's good to memorize a little bit these. The others are less common. Concussion can cause syncope, transient loss of consciousness. Some seizure disorders, they are not, don't cause 15 minutes of tonic-clonic seizures. They can look like a transient loss of consciousness, so they can be cause of syncope. Psychogenic is also common. And the metabolic, here, hypoglycemia is not really something that causes transient loss of consciousness. Maybe dehydration or some hypovolemia may cause that. But again, neural mediated is most common. Here is the typical vasovagal on the soldier side who has been standing for too long. The tachycardia that happened on a warm day kind of ran out of juice and then eventually dropped the blood pressure and then passed out. While the bats on the other side is more the orthostatic. When somebody comes up or sits up from a laying down supine position or gets up from a seated position, then suddenly all the blood goes to their feet, which is normal, and they're going to have orthostatic hypotension. If the orthostatic hypotension gets to the point that there is not enough blood goes to their brain, then they pass out. So here's the mechanism of that, and you can see the orange part inside the body shows you where the blood pools. So in supine position, it pulls in the central area, in the chest, in the heart. And so even in a hypovolemic patient, they have normal cerebral perfusion. Actually, this is the reason why you put somebody in Trendelenburg in order to, prevent syncope. When they get up, you can see again that now suddenly it pulls in the veins. The younger you are, the more it pulls in the veins. So a young, healthy teenager will have lost half of its blood that previously was in the chest cavity and the heart, then goes into the brain. So the less comes back to the heart, less blood goes out to the brain. With that cardiac output, then there will be less, perfusion to the brain, and then a lot of times it can switch off. So this is the typical orthostatic hypotension. Well, so one important part on the side you can see um, is a physiologic response to getting up from supine position to standing. Because of the venous pooling, the central blood volume goes down, the stroke volume goes down, and the cardiac output goes down. If the patient does not faint, there is a baroreflex regulation that kicks in, which increases the heart rate. Is that pathologic? No. Can the heart rate jump up by 20 points? Easily. So that's not POTS. It's very important to show that orthostatic tachycardia doesn't equal orthostatic tachycardia syndrome. POTS is diagnosed by having tachycardia, meaning more than 20 points or more than 10 points, 10 minutes after standing up. So you have to have that patient stand up for 10 minutes, and they should be still tachycardic 10 minutes after. That's when they get the POTS diagnosis. The usual heart rate elevation is normal in everybody. So just because somebody has orthostatic changes in position change, that's basically normal. I usually, if they have syncope because of this, because of orthostatic hypotension, I usually advise them to hydrate much more, because if their tank is filled, they will have less likelihood to have hypovolemia and decreased cerebral perfusion, and that they can prevent syncope with that. Or if they feel it coming, they can go back down to supine position and they can prevent syncope with that. The next one is reflex syncope. This is a patient who was at a blood draw, and you can see there is an 8.8 second pause. So basically, it's just an exaggerated vagal response that causes asystole in patients who are sensitized for certain things. This is the reason if somebody faints because they have a sudden pain in their belly, or they have a pain in their extremities, or they are poked, or they have a sight of blood. So whatever turns that on, it can cause an exaggerated vagal response, and then you can imagine how that makes a syncope. So do they need a pacemaker here? Absolutely not. They need to be desensitized from the trigger. And so that's, the important part. Again, just a couple of examples of common etiologies of syncope that are not cardiac. And now let's just turn on to the cardiac part, and then again, a couple of hints of how you diagnose or how you can suspect a cardiac origin. So what is a syncope because of a cardiac origin? It's a non-perfusing tachyarrhythmia or an AV block with bradycardia. These are the two reasons from the rhythm standpoint. So non-perfusing tachyarrhythmia, SVT is usually not in the picture. SVT only faints people who are dehydrated to start with, or old people. It usually doesn't make little kids or teenagers faint. But VF or VFib and ventricular tachycardia VT, that can make you faint. So those are the two things that I want to rule out, especially ventricular fibrillation. So when you think about syncope because of a cardiac origin, think about VFib as number one. And then sudden onset of AV block and bradycardia. That can be also a cardiac origin, such as in acute myocarditis. And then the last part is terminal heart failure, not the last part. One more is terminal heart failure with hypotension. You have to have such a bad cardiac output and so low left ventricle ejection fraction that you don't push out too much blood. And that can again happen in acute myocarditis or in just terminal heart failure. The last one I would like to put in here, if you have terrible pulmonary hypertension, that is actually one of the concerning symptoms of pulmonary hypertension. When you, again, cannot push out any blood, you have an acute cor pulmonale and limited cardiac output. So again, this is the summary slide about cardiac origin of syncope. So if you remember anything, remember these, and these are the ones that we try to figure out. So VT and VF, so ventricular tachycardia, ventricular fibrillation. Basically, those are, if they result in syncope, those are super strong reasons why the patient could also have a sudden cardiac arrest or sudden cardiac death. And here we are looking for inherited arrhythmia syndromes or channelopathies or cardiomyopathies. So what are those that I'm looking for when I'm suspecting a cardiac origin? Is long QT syndrome, Brugada syndrome, hypertrophic cardiomyopathy, dilated cardiomyopathy. The other one is AB block. And then the third one is circulatory compromised in decreased heart failure. So when you think about this, you can think of what do you need for diagnosing them. And the diagnosis comes usually with EKG or echocardiogram. Here is an example how you can have ventricular tachycardia in a patient with an underlying long QT syndrome. So you can see a simple EKG can diagnose a really, really long QT, and then you have the diagnosis of that cardiac origin of the syncope. Another EKG I put up there. This is again long QT syndrome. You can see how long the QT is on this patient. So these are again EKG diagnoses. Uh, there are different types of long QT syndrome that I don't want to get into the detail, but again, the whole point is potential causes of inherited arrhythmia syndromes can be diagnosed by EKG. Short QT syndrome is another rare cause, can be diagnosed by EKG. They lead to the same thing, which is usually torsade de pointe, which is a twisted VTVF. Here is another picture of torsade. And then on this EKG that is coming up, I show you a Brugada syndrome that is abnormal in V1 and V2. This is not for you to remember. The only thing that I want to show with all of this that all of these inherited arrhythmia syndromes that usually cause VF can be diagnosed by EKG. Here is another tracing of how long QT gets into VT-VF, and then another ventricular tachycardia with CPVT that can be deadly. Another EKG, I know it's rapid sequence. You don't need to remember them. I just want to show you how much EKG is important. This is a patient with significant ventricle voltages, big R waves in that V4, V5, V6. And this can be because of hypertrophic cardiomyopathy, sometimes because of dilated cardiomyopathy. Here is another EKG example of dilated cardiomyopathy. Again, please look at V4, V5, and V6, and you can see that the T waves are negative. So again, just examples how important the EKG is in syncope evaluation. There is another EKG here that potentially can cause a cardiac origin of syncope and either sudden cardiac death, which is Wolff-Parkinson-White syndrome. That's again an EKG diagnosis. So when you think about syncope and you think about cardiac causes, EKG is the most important. So when you have syncope, transient loss of consciousness, and you can rule out those common neurocardiogenic causes, and it's very easy to rule them out because if you get up from supine position and you fainted, okay, that's unlikely to be because of hypertrophic cardiomyopathy or long QT syndrome. Or when you were standing long in church and then you fainted and you got back up without any intervention, that's probably vasovagal. Or when you had a big belly pain or they wanted to do a blood draw and you fainted there, again, those are all neurally mediated or neurocardiogenic syncope. And you can see that I didn't need to do any kind of test to figure that out. That's why, again, your most important weapon in sorting out the etiology of syncope is a detailed history taking. Then in the case when you have a syncope that you suspect a cardiac origin, EKG is your best bet. So again, EKG is the most important test in there. So again, what do you need to do for syncope and very detailed history taking? You can have a physical exam because if you have a heart murmur, that may point towards a cardiac origin. And then my recommendation would be to get an EKG. The EKG does not need to be at the time of syncope. It's a little different than chest pain because you can see how many things you can potentially diagnose with an EKG that could point to a cardiac etiology. So I would always get an EKG when you have a patient who you suspect a possibility of a cardiac etiology. Here are again the, so to say, green flags. So syncope that happens with postural change, that usually is benign, on a hot day, standing in line, after a hot shower, or when combing my hair, or straining on the toilet. They have a typical prodrome. The patient feels it coming. They have visual changes, sometimes hearing changes. They get a little dizzy, and then they don't remember anything. There is quick recovery and usually no need for CPR. Opposite of that, red flags. If it happens during exercise, if it happens in the middle of exercise, I'm really concerned. Or it happens immediately after exercise, that's also concerning. A lot of times when I hear a patient coming here, do you have a chest pain? Yes. When? During exercise. Okay. Tell me exactly what happened. Oh, well, I was running. Then we finished running the mile. I sat down. I talked to my friends. Then I was really, like I felt a little headache and I got up after like 5 minutes. Well, that was a totally orthostatic hypotension. So it's very different than during exercise or immediately after exercise. Another potential red flag would be that if there is absolutely no recollection and they injure themselves, and obviously if the patient needs CPR, then syncope is not really the diagnosis. Then I would go with the cardiac workup. So again, for syncope, when do you need to do echocardiogram? And now this is almost the first time I say echocardiogram in the entire evaluation. So just remember, chest pain and syncope, history and EKG are more important. You only order an echo if, and the same three things here, then chest pain. If it's exertional. So if you're an exertional chest pain, exertional syncope, you can order an echo. Or if your EKG was abnormal, or if there is a sudden cardiac death history. So again, in just quick summary, these are both super common, 99% of benign. Hopefully I showed you a couple of examples how to sort out the benign, and then the 1% is associated with a potentially lethal cardiac condition. So we need to figure out that needle in the haystack. And again, a summary, history taking is the most important. Red flags, if it happens during exercise, or if associated with family history of sudden cardiac death, or if your EKG is abnormal. Possible cardiac causes of chest pain is pericarditis, myocarditis, and coronary artery abnormalities, and possible cardiac causes of syncope are channelopathies or cardiomyopathies. So I would refer these patients or get an echocardiogram only if exertional, you have an abnormal EKG or a positive family history. Thank you very much for listening. And again, open for questions. Here is a list of references. I did not put the references in between, but I'm happy to provide you with all of these if you want to review it.
Thank you again. Are there any questions? I don't see any in the chat so far, but folks feel free. Oh, you're right. We should do the questions. Let's go over the post-session questions, and then we can review the answers in a couple of minutes. If you have questions for Dr. Brattensack in the meantime, feel free to put them into the chat while you're doing the little quiz.
So what is the single most sensitive test for finding cardiac etiology behind chest pain in pediatrics? I hope you know that now.
Um, are we starting to see some answers come in, Summer?
No answers yet. I think they're pondering.
Okay, there's another question from Renata. If large heart from hard work, how to differentiate from hypertrophic cardiomyopathy? I don't know what large heart, um, I don't know. My training at least is that large heart is usually always bad. Is there any kind of normal large heart from hard work? Am I misunderstanding something?
So Renata, is it hard work meaning an athlete? I don't know if they can answer. So let's say if it's athlete, then yes, an echocardiogram can differentiate a benign hypertrophy with completely normal systolic and diastolic function versus a cardiomyopathy kind of picture. So in that case, if you have some evidence, let's say you take a chest X-ray for whatever reason, and the chest X-ray clearly says that is cardiomegaly or large heart, then you kind of stuck with that, and then an echocardiogram would be the appropriate test that can differentiate abnormal and normal.
Thank you for clarifying. I also didn't know that you could get a large heart from being an athlete. So
Just like it's like a little thicker and
makes
a
sense.
little dilated, so it's
Mhm.
just able to push more.
Great. Yeah, that's good to learn.
And we're
Are we
about
getting answers to the
yeah,
question?
I'm gonna end the poll here. And Andres, if you could just go over number 3, I think that one is split right down the middle.
Okay, so the first one, history taking, excellent. Second one, what is the most common cardiac finding in children in this list with reported chest pain? Pericarditis, perfect. And then what is part of the initial evaluation of syncope in children? So history is absolutely correct, but initially, because there are so many causes of channelopathies and cardiomyopathies and yeah, for a cardiac cause. So, I would say maybe I didn't pose this question right, because if you say what is the initial evaluation of syncope of children, all of those who said history, they are correct. I would only use history. But those are also correct who said both 1 and 2, because what is the initial evaluation of a cardiac etiology of syncope in children? Then I would choose history and EKG. So I think I was wrong in posing this question. I would say if you have syncope in general, history is the right answer. You figure that out. And if you are worried about a cardiac etiology, then you put EKG as a next test.
Thank you so much for clarifying.
Not
We're
at
at
all.
time. Thank you for wonderful and, as always, very educational and practical